You would also so there are so many things that you can actually pick up there. You can, I mean, some women can just come in for a scan and then you pick up other things that they're not even aware of. So I that's one place that I enjoyed working in. So that's what I was doing as someone who was running maternity. I was doing that every day, just in that sequence, and do scissors. When I was there, I tried to minimize scissors as much as possible. I will tell you how I managed to minimize scissors there. So I would have days where I only have about 3 scissors a week, not days, week. I would have days where I don't have a scissor at all. I would have weeks where I just do maybe 2-3 scissors. If I do 4 scissors a week, that would be a very horrible week for me, because usually I don't have a lot of C-sections, and I will tell you why, like I said, right? So so now, as a GP working in obstetrics, just you know your strength and you know your weakness. One thing that you know is that you are not a specialist, so you must know that there are patients that you will not be able to manage, and there are patients that you're going to have to refer. You're going to have to refer for a specialist opinion or a specialist care, or to be operated on the other side. So patients that have delivered by C-section 3 times and more, those ones we used to send. Those ones we used to send for their next C-section. We used to send them to be actually done their C-section at a tertiary hospital, right? So so that is what those were my duties when I was working there. So now, what are the things that worked for me? What are the things that I would advise you guys to actually pay attention to if you're gonna be working in maternity? So guys, one tip that I'm gonna give you a couple of tips, but the first one is, never be called in maternity for a patient and give orders over the phone and not go and actually see what's happening. Personally, when I get a call from maternity, after I've spoken to the person who was calling me, I stand up and I go and assess the patient. So avoid giving orders over the phone and not go and see the patient, because sometimes when you get the picture that you see can differ from what you were told, or from the impression that you got when you were talking to the person you're talking to over the phone. You can get a complete different picture because of a couple of reasons. So to avoid getting into any trouble just because you didn't go and see a patient yourself, just go and see the patient, right? That's number 1. Number 2, try to do a lot of scans as much as you can during your training, your undergrad training, during your internship. Try to do a lot of scans. Work in maternity without knowing how to do a basic ultrasound, a basic obstetric ultrasound. You can't, because there are so many decisions that you're gonna depend on the ultrasound findings to actually make them. Like, a woman comes in with PV bleeding, they are pregnant. The only way you can see that this is a placenta previa is doing a scan. Because remember, you cannot do a digital exam on a PV bleeding. You can't do a digital exam, digital PV exam on an APH patient. So the only way you can actually pick up if it's a previa, it's by doing a scan. The only way you can pick up if the heart activity of the baby is there or not is through a scan. Yes, you can do what is this thing, a CDG, but a scan is much more, especially if you want to confirm and start inducing a patient who you think has got an IUFD. You want to do that scan and see that heart not moving and be sure that this heart is not moving, and you can do that via scan. Twin pregnancy is very easy to pick up on a scan. And what else? Dating. To date a pregnancy, you're gonna need a scan. It's the other methods, but you can still use a scan. So a scan, having that skill will help you a lot. Yeah. So, and also one of the things that you guys must pay attention to when they induce a patient, be it post dates or be it IUFD, pay attention to how they induce patients. One of the things that I did when I came this side is to induce patients using a catheter, a Foley's catheter. And I saw this when I was doing 30 and I never saw it again. I saw this method when I was doing 30. And then throughout my undergrad training, I never saw it again. And even during internship, I never saw it. And I had to come and do it, right? So you must try and understand how to induce and when to induce patients. And you must, the two methods that I was using there was the cytotech method and the balloon method. I'm not going to get into the indications of each, but the balloon catheter is the safest. Whether you have had a previous seizure or not, it's the safest. And there are patients where I would use both cytotech and the balloon, and I had a very good success rate in terms of inductions. Very good success rate, and that's one of the reasons why my C-sections dropped. When I got to maternity, I looked at the stats and I saw that all the other months before I was there, the C-section rate, they would do about 40, 41, 42 scissors in a month. That's their stats, and it's always been around that. But on my first month, I cut that number to 28. Second month was 29. The last month it was 28 again. So basically about 10. I was doing 10 scissors less than if you compare the stats of the time I was there and the previous month. And the reason for that is, one big reason is because I only took a patient to theater once who had a failed induction. You hardly get a failed induction when you combine the two methods, depending on the indication, like I said. But balloon catheter combined with cytotech is very good. It has worked about more than 90% of the times, right? So you must be, because the thing is, if you don't know how to induce, you're gonna have a high scissor as a doctor, and you don't want to have a high scissor rate. I know there are people who likes it, but you don't want to have a high, because I mean anything happens in theater. And you want to try and make this woman to deliver on their own. And then now when you have to actually take them to theater, then you take them to theater. So you must follow protocols. You must know the protocols and follow the protocols. So fortunately for me, when I was there, there's only one instance where I had to deliver a breech. There's only one instance where I had to be called and deliver a breech. I didn't have a lot of that kind of complications. And in theater, the patients that's another thing. Guys, try and cut as many patients as you can. During your internship, try and cut as many patients as you can. Try and do a lot of C-sections. It's going to help you. It's gonna help you, because when you come here, there is no one who's gonna be very patient with you and give you 6 months. You cannot come for your ComServe in January and then you start doing C-sections in March comfortably. There isn't, doctors are few, and there is no one who's gonna always be there. Imagine in the districts, if you wanna do a Caesar, one doctor will do the spinal. We always do spinals here. Where I'm working, we always do spinals. And then now it will be you, and then now you're gonna have a third doctor to come and assist you, to come and be with you when you're doing a Caesar. Imagine if you're gonna do that for 3 months, and in the hospital where you're working, there's only like 6 doctors. It's not gonna work out. That's why people are always pressured to actually get on with the work and finish the work. So there isn't a lot of patience. I don't wanna lie, there isn't a lot of people are frustrated. I mean, healthcare workers are frustrated people, and there's no one who wants to babysit anyone forever. So do yourself a favor, start doing those scissors. Start doing those scissors. It's gonna help you. I did my first scissor on my second week. That's when I did my first scissor, and in the same week, so I was assisted in 2 C-sections. I knew that I needed only about 2 C-sections before I can do them on my own. So I got that, and I was like, okay, because it was just a matter of, because I did about 11 C-sections. I'm not saying that's enough. I did about 11 C-sections during my training, and I knew that if I can do 1 or 2 in the presence of a senior, then I will be able to actually start operating on my own. And that's what happened. And I did fascial abdomen surgery previous that ×1. Personally, I do up to ×1. I've done up to ×2, but it's exhausting. Those things called adhesions, guys, they mess up with the anatomy, so the chances of having complications are very high. So personally, I don't take to theater anyone who's who has been cut more than once. I only take previous scissor ×1 and someone who has never had a scissor before. That's where I end. In any case, I'm not planning to be an obstetrician, so I'm comfortable doing that. Now, guys, I've always talked about people who want to specialize before they specialize. If you are those kinds of students or interns who only pay attention when they are rotating in a specific department and not care about all the others, that time is going to catch up with you when you come for your ComServe, because you'll be taken to PEDS. And imagine going to PEDS and you were that person who never paid attention when it comes to PEDS, because you knew that you wanted to do anesthesia, or you are taken to internal medicine, or you love ortho, but now all of a sudden you are allocated in internal medicine. What are you gonna do? So don't specialize before you specialize. I mean, go rotate. Wherever you rotate, give it a push, try your best, so that by the time you have to make decisions on your own, you are safe. You are able to be a true GP. If they throw a psychiatry patient, you are on it. If they throw a pediatric, you are on it. If they throw an obstetric patient, you are on it. Gynae, you are on it. So you can only do that if you treat each and every rotation with respect and actually do what you're supposed to be doing. And I mean, don't depend on your seniors telling you what to do all the time, because if you come this side where there isn't anyone who's actually, because there's no consultant, there's no registrar, so there's no one who's actually breathing on your neck to make sure that you do your work. What will make you to do your work is your whether how ethical you are and how diligent you are, and also how professional you are. So those are the only, so if you happen to lose those, you're gonna be in trouble in the districts, because there isn't really anyone who's asking you why are you coming at 8:15? Why are you coming at 8:30 at work? Or why are you leaving at 5:30? Or why are you leaving at 2? There is no one who's going to ask you those kind of questions. You just have to man up and be a doctor. You just have to doctor up. Let me just put it that way. You just have to doctor up and actually be a team player. And I don't want to lie to you. I'm going to meet people who are horrible team players. Even in the internship, there are people who are horrible team players. There are people that, I don't want to get into that, but we always have those people. So anyway, guys, that was my experience in maternity. And in terms of, maybe you want to know how many complications have I had. I've had a couple of instances, I think about 2-3 instances where I operated on a patient and I take the patient to the ward only for the patient to keep bleeding, and I have to take the patient back to theater again and open and check where the bleeder is. I mean, I think that has happened about 3 times. And this one other time, when it happened, I actually had to go, and I didn't have like a true bowel injury, but it was the, the visceral peritoneum that actually covers the part that covers the visceral peritoneum that covers the large colon. For some reason, I was operating on a previous set of times one, and it was torn, and the patient just kept bleeding, and I took the patient back. When I called the other guys, we opened the patient up and we realized that there was no bleeding in the uterus and there was no actual artery that was bleeding. It was just that peritoneum. But luckily, I managed to close it, and the patient stopped bleeding. So those are the minor complications that we've had. But by God's grace, we haven't had major complications. And I'm not saying we will never have, but there isn't a major. I've not. The time I was there, I've never lost a mom. I've never lost a baby. So for me, it's exciting because I'm just a junior and I was working in maternity for the very first time alone, and I'm quite happy. But by the time I was leaving that place, I couldn't wait to leave because it was exhausting, very exhausting. And I mean, in maternity, the thing is, you can have a C-section at 3:30, and you think that maybe by 4:15 you'll be done, or maybe that by 4:30 you'll be done, but it just takes you longer. And there are times I would leave a hospital at 6:30, at 6. Sometimes there was a time we left at like 10 o'clock, and there are times you will go in early thinking that you will finish work early, maybe around 3, around 4, but you just have a horrible day and you end very late. And so yeah, I was very tired. I couldn't wait to leave.